Hello, everyone. My name is Elisa Konofagou, and I'll be talking to you today on the technology requirements for the pediatric patient that we have found as part of our DLPG trial. So for our focused ultrasound blood-brain barrier opening system, we're using something that's outside the MRI system. There's this infrared camera that is registering the transducer with existing MRI through fiducial markers. And the actual subject is in a chair that looks a little bit like this, immobilized with a transducer in different parts of the head. As I'm going to show later, that is going to change from the two clinical trials that we have ongoing, from Alzheimer's to the DLPG study. But there's 4 different steps into what we're doing as part of the system. First, we predict the targeting, make sure that we have the right region of the brain. Then with simulations, we see whether that's feasible to have a uniform focus in that region. And then we monitor the actual event of cavitation that allows us to see where the opening has happened, either with the PCD or passive cavitation detectors for looking at whether the bubbles have gone into the region of the focus, or with what you see here, which is a map of the cavitation event. I'm going to end with that as part of my presentation. And then finally, we take the patient to the MRI with contrast enhanced MRI to see whether how close was the actual opening to what we planned. As for the treatment planning, what we have here on the top left is actually how we register the infrared camera with the actual facial characteristics of the patient. There are 3D renders from MRI. And the transducer here, you can see that has this shape that has a ring that has a void in the middle. That's where the PCD detector goes. And then with numerical simulations, we're able to, very similar to what I showed you earlier, see where it's going to land. This is part of our Alzheimer's trial, where we have a transducer coming from the right temporal lobe. And we can form a focus here that after filtering for -3 dB, we can see that it is uniform in the prefrontal cortex that we intended. We published over the years the aberration effect of the skull, so that creates typically a focal shift. So that's on the order of about 2 to 3 millimeters, lower in the lateral of the axial dimension, but we're able to predict that and correct for that. And of course, the simulation, we have also evaluated that as far as the accuracy of the predicted focal spot. This is what the actual setup looks like. So I mentioned that we have a transducer that's registered with the infrared camera, and I'm going to show you a close-up of the fiducial markers that are shown here in a triangle tripod configuration. The transducer phase is here. We use 0.25 megahertz focused ultrasound transducer. There's a robotic arm that can very precisely, millimeter by millimeter, position this transducer. And as I mentioned, the passive cavitation detector, you can't really make it out here, but it's in the middle of the transducer focally gathering signals and images, depending on what kind of detection you're doing from the region where the opening is happening. And then this is registered with existing MRI of the subject. And you see here that the crosshairs are showing where we're actually targeting. Ideally, this can be done with this bullseye view, and you want to make sure that this red spot is hitting the origin of this crosshair. So there's 2 clinical trials, as I mentioned, that we currently have ongoing in Colombia. Obviously, the second one is what we're interested in as part of this workshop. The first one is what we started with last year, and I'm going to start with that, where we are recruiting Alzheimer's patients. And this is exactly the same setup that we have. And we have this IDE for 6 subjects from MCI, early Alzheimer's. And we make sure that the subject is comfortable into this chair, and overall the actual treatment can last less than 30 minutes. This is a close-up of what I mentioned before. The transducer is right here, and this is the actual patient here sitting in the chair, a close-up of the goggles that we use to register the eyes. And we have this on the prefrontal cortex targeting through the temporal bone here. The robotic arm close-up here, the reflected beats are the fiducial markers that the actual infrared camera can register. And then the hole here, as you can see, the actual PCD or imaging array that can gather the cavitation section. There's a water cone that can be also inflated, and we circulate water to make sure that this gets also cooled during the treatment. The treatment location in this case is the prefrontal cortex, and you can see that we can predict the actual focal spot through the simulation. And again, this is the configuration that we used for the actual prediction of the incidence angle as well as the tilt of the transducer. And these are some of the signals that we get in real time now with cavitation detection from the Alzheimer's patient, an actual signal from a patient. And you can see that the harmonic, ultra-harmonic, and inertial cavitation throughout the 2 minutes of sonication can be very carefully monitored, with the harmonic showing the actual stable cavitation of the bubbles, and the inertial cavitation showing you the eventual popping of the bubbles. So ideally, we want to keep the red curve as low as possible, and you can see here that this is a logarithmic scale that shows that we have at least 10 times lower inertial than harmonic. The patient setup looks exactly like this. We have this chair that looks almost like a dental chair. The robotic arm is right here, and this is the infrared camera where we're adjusting to get the bullseye that I mentioned at the crosshairs. This is something that I showed before, and this is on the bottom right is what we actually have as real cavitation signals coming back to monitor safety and overall the bubbles that are coming in. See the rise time here of the curve shows that the bubbles are coming into the focus. And this is the results that we had on our first opening last year. Well, is the region that we targeted in all 3 slices of this contrast-enhanced MRI, and the opening volume was around 4 centimeters cubed. Now, for the second clinical trial that started almost a year later, but very recently, as of August, we have to go from the back. So typically, as we know, the pons in the DIPG, we have to go through the back of the head, the neck of the patient. So thicker bone overall than what we had in the cortex. Also define some of what gravity, especially with a coupling for the transducer being vertical. But overall, we can get a very nice landscape formed here in blue focal spot in the region, the intended region. And these are the 3 orthogonal slices for the pediatric tumor planning, showing obviously the longest dimension of the axial with the single element transducer, and shorter dimensions of the coronal side. This is the actual the picture of the second patient. I'm sorry, where we have targeting that region of the brain. We do partial shaving. The gel here, that's the gas and coupled for this to the skin, and overall very similar setup as I showed you before. Very similar to what I showed you also before was the real-time cavitation monitoring, showing the bubbles going into the region and being sustained with ultra-harmonic and harmonic, but also inertial in this case. And the opening was very targeted in this region of the gray matter, in the very close in the pons of the actual pediatric patient. That was with a patient 1. And patient 2, very similar cavitation level. This is actually the spectrogram of that, showing us the frequency content at the same time as the time or distance. And we could also see a more diffuse cavitation in this case, a larger region of opening in this second pediatric patient, which we were able to have a contrast-enhanced region in that intended region. So the last thing I want to show is actually the mapping that we're doing as opposed to just a single trace PCD. This is from the actual pediatric patient 2, where we're able to go into the pons and look at the actual focal spot, and we can do this in real time, so 0.4 seconds in computation time, with a coherence factor passive acoustic mapping. And we were able to identify that the intended focal spot was actually where we wanted it to actually land in the pons. hence the opening that we saw in the previous slide. So overall, we have these 2 clinical trials currently ongoing. We're performing treatment planning simulations, and the patient setup is very simple, portable, and also efficient. We perform real-time cavitation mapping, and we have MRI assessments after the opening, and the entire application is about 30 minutes. Now we're designing new chairs with better cushioning and immobilization of the head so that the patients don't have to rotate at all. We're going for faster and real-time mapping, also more consistent, and we can get the potentially the angle of incidence in the skull. And the entire application, we want to have it to a mere 15 to 20 minutes by making this much more efficient. I want to thank my group, all these people that have worked hard in these 2 clinical trials, the collaborators at the Urban Cancer Center, all our sponsors, and my entire lab. Thank you.